السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا ومساء الخير. A very warm welcome to everyone and thank you for joining us today in the basic dermatology curriculum organized by the Saudi Society of Dermatology and Dermatologic Surgery. So just for the new attendees, this is a 5-week educational course running from November until mid-December, and this will be a recorded session and will be made publicly available on the Society's official platforms after the course completion. Also, please note to type your questions in the chat and we will go over them with Dr. Asem at the end of the session. And also to notify you all that all course content, including the slides, recording, will be shared with everyone, and we will announce the access links on our social media platforms. So our session today will be delivered by Dr. Asem bin Shadid. He is consultant dermatologist, European Board of Dermatology and Venereology, and he has also the Saudi Board of Dermatology and Venereology. So thank you very much, Dr. Asem, for joining us today. It's a pleasure and honor to have you with us today.
شكرا حورية على الانترودكشن، شكرا على استضافتي. أهلا فيكم جميعا. كيف حالكم؟ أنا دكتور عاصم بن شديد، بورد سعودي، بورد أوروبي. Everybody here speak Arabic or there is some people who speak English only? So I can explain in both ways or no?
أتوقع إنه أيوة it's fine. I think الحضور يعني ممكن يكون في ميكس وكده I think حيكون كده تمام. أيوة.
طيب. Okay. Welcome all to our great specialty. Dermatology is one of the nicest specialty worldwide. It has a lot of competition. It's always missed look in dermatology in the curriculum of medical school in general. It's a big science. It's a science that include almost 3 science inside of it: dermatology, pathology, pharmacology, and now we can add dermoscopy to it. My lecture, it will not take a lot of your time. I will talk basically about the anatomy and the physiology of the skin. Then we will go through a very quick review of some of the most common medication used in dermatology clinic. I have an advanced lecture for whoever interested in knowing about the anatomy and the physiology of the skin. It's divided into two parts. We dig very deep into the skin, the structure of the skin, how does the cell communicate with each other, what are the components that hold the skin together. I will not go through them. It's an advanced lecture for anybody who's interested. It's on YouTube. You can Houriah share the link with them after the session. Okay. So we will talk. We know all. The skin is divided to multiple layers: epidermis, dermis, hypodermis, etc. The most important thing that I want you to understand as a beginner, that we have 4 areas. The skin is different in the anatomical structure of it: the palms, the soles, the genitalia, and the scalp. Okay? Any other place in the skin, it's similar in anatomy. Okay? We'll start by the epidermis. The epidermis is an avascular layer. This is very important. So it doesn't have vessels. It's most likely cells. This will help you a lot in understanding the disease physiology that happen to the skin. So we have multiple layers. We have stratum corneum, stratum granulosum, stratum spongiosum, and stratum basale. Okay? Let's see them on pathology. We have additional layer that is in palm and soles that called stratum lucidum. This is important because when you give medication, topical medication for palm and sole, you have to put in perspective that we have extra layer of skin, so I have to give a higher dose or a higher concentration of the medication in order to get absorbed in the skin. Okay, so stratum corneum, it's a layer with, if you can see, most of the cells here have nucleus. When they come here, they become without a nucleus. Why? Because, subhanAllah, the skin from outside, it need to be like a brick wall. It need to be stick together. It's like a house. So the most outer layer, it should be with no spacing between them, with no connection between them, and all they are sticking together so they can protect the skin from microbes and from different stresses, sun, etc. The interesting information that I need to tell you is that in the stratum basale, this is the only mitotically active layer of the skin. This will help you understand a lot of diseases and help you understand a lot of treatment. How does it work? So this is the mitotically active layer of the skin. The journey from here, so the cells start from here and they end up here. So the journey from here to here is 14 days, okay? And the journey of the cell to become from this cell to this anucleotide cell is another 14 days. So in total, we have 28 days for the journey of the cell from here to here. That's why a lot of improvement when you give medication, you will see after 28 days, okay? And a lot of diseases take sometimes 1 month to develop because of this information, okay? So this is all advanced, you don't need to know about. Just very quickly, we have multiple connection between the cells. In the stratum basale, the connection between the dermis and the epidermis is called hemidesmosome, and the connection between two cells is called desmosome. This is the connection, okay? We have, of course, this is the journey that I was talking about. We have the stem cell, we have the transient amplifying cell that has become differentiated and become the multiple or different layer of the skin. Okay. I have very interesting information I want to share. Just very quickly, what make the mitotically active area active? So they found that there are some outside like changes like UVB, okay, or trauma to the area that make the cell more active, okay? Why? Because we have an enzyme called ornithine decarboxylase. This enzyme is stopped by three things: retinoids, corticosteroid, and vitamin D analog. That's why when we have like hyperactive disease that cause cells to proliferate, like psoriasis, like implanus, etc., this enzyme will increase in activity. And when you think about it, we give always topical corticosteroid, right? Because it will stop this enzyme, okay? This is information that they like to ask about all the time. So three things: vitamin D analog, retinoids, and corticosteroid. Okay, so the outermost layer of the skin will look like this: cells with multiple ceramides, with multiple connection between the cell that make the brick wall. That's why you now see most of the company, when they develop moisturizer, they develop moisturizer with ceramides, because it is the protection, the gap between the cells. Desmosomes and homodesmosome, multiple connection between the cell. I explain all in my advanced lecture. You can have a look at it. We have, of course, between the epidermis and the dermis, what we call dermoepidermal junction. A lot of diseases happen because of the problem between the connection, okay? Also, this is interesting when you look at it in consideration of the bullous disease, like bullous pemphigoid, and etc. It's all explained in the advanced lecture, okay? The dermis, we have two layers of the dermis: papillary dermis and reticular dermis. They differ in the type of collagen. So collagen type 3 is usually in the papillary dermis. Collagen type 1 is usually in the reticular dermis. And these type of collagen are the one that we try to improve when we inject biostimulators, okay? So that's why it needs to be injected in the dermis, because the fibroblasts are there. Okay. That's finished the anatomy part. Of course, they will discuss in details how to describe lesions and how to know the different type of lesions. They told me this is not the scope of my lecture. However, I have an easy way to describe a lesion, I'm sorry. So when you want to impress your professor or you want to write a note, you want to write the prescription of or the description of the lesion, how you will say it. So remember this mnemonic, hashtag DC21L. What does that mean? Hashtag mean the number, and I will give example now. Okay? D mean the definition. C mean the color. 2 mean this secondary lesion first, then the primary lesion second. So 21L, and then the location. I will give you an example. Imagine that I have a scaly lesion, a red scaly lesion here in my hand. So you will start by the number. So you will say single, then you will describe the definition. Most of the dermatological problem are well defined. So single, well defined. Then you will say the color. The color, you can say erythematous, okay, or violish in color. We have specific name for each color. Then you will start by the secondary lesion. Secondary lesion, what does I mean by that? The most two popular are either scaly or crusted. So if we are talking about psoriasis, you will say erythematous scaly plaque or crusted papule over the dorsum of the left hand. So if I'm going to repeat very quickly, I will say the patient have single, well-defined erythematous scaly plaque over the dorsum of his hand. You will always impress your professor. You will always write the note correctly, and this is the correct way even to write it in literature. Okay? Very nice slides I will share with you about the pharmacology review in the clinic and even for anybody who want to study dermatology. It's done by one of my great colleague, Dr. Abdullah Al. The last update was in July 2022, but I think we updated more most recently in 2025. So I will send you his specific slide, but I will show you how is the structure of the slides. Okay. So each slide, he put the most important information for you all. Like here, for example, let me try to put this down. Like here, for example, he will start by the biological therapies, like anti-TNF alpha. So he put all the medication here. He put the mechanism of action, the form, the doses, any important note, and the side effect. This will become very handy in the clinic. Everybody should download his slides and keep it in his phone because you sometimes need a quick review or quick information about the drug that you are going to give. Okay? Also, he described it a little bit advanced for some of you who is interested, but the most important are the tables. I will go through the most important thing. Of course, these are all the biologic that we use in psoriasis. This is the biologic we use for atopic dermatitis. This is for bullous diseases, IVIG, for most of the connective tissue diseases. Everything you will find in his slide. This is JAK for either psoriasis, atopic dermatitis, or alopecia. So please keep these slides, and I'm really grateful and thankful for Dr. Abdullah Al. I will discuss the most important medication, which is the corticosteroid, okay? So apremilast, immunosuppressive like AZA, cyclosporin, everything you will find here. Like, for instance, doctor told you to prescribe methotrexate. You open the slide, you see very quickly what's the approved dose, what are the labs that you need to do before you start, and what are the important things you need to know or educate your patient about. Because sometimes you will be asked to educate your patient about the side effects. So you see here very quickly, GI is the most common. Maybe he will have a hematological problem, liver problem, etc. Okay, and you have always the contraindication. You have to ask always about the contraindication. Okay. And you will find sometimes like this very nice tables from Wolverton. He will put after any slide, like here for methotrexate, you need to order CBC, LFTs, hepatitis B, C, and HIV. Okay, never ever don't be shy from your professor. Okay, especially in the beginning of your career. If you don't know, just say I don't know, or I will double check, especially with dangerous medication like biologic or methotrexate, okay? Immunosuppressive in general. MMF is also another important medication. Anti-malaria, we prescribe all the time. Dapsone, colchicine, you see, he put everything for you. Hormonal, it's rare to prescribe in governmental hospital, but it's also possible. Antihistamine, he put the first generation, the second generation is very important to know also. Okay, retinoids, we have different type of retinoids. You can look at them at your own time. You need to read them by yourself so you can understand every and most important point of each one of them, okay? I will go to steroid directly. Okay, steroids. We have different category when coming to topical corticosteroid. I will give you just a general rule, okay? A general rule and a very easy rule to decide what type of topical corticosteroid you can give in the clinic. Okay. I like to like simplify it as following. Any lesion you have in hidden neck, or hidden area, like genitalia, axillary, under the breast, it's hidden area, right? They start with H, hidden area, hidden neck. So the safest is hydrocortisone. Okay? You will always give hydrocortisone in this area. Great? Okay. If I'm thinking body or the main body, we will give either betamethasone or mometazone. So remember, B and M, main body and body. Mometazone and betamethasone. H, head and neck and hidden area, hydrocortisone. Good? Clipping, nail clipping. Okay? So remember, palm and soles, you will give the strongest cortisone we have, which is clopidogrel from clipping. Remember, nail clipping. You see, we have different type in between, okay? Anything that we add dipropionate to it, it's become high potency, okay? So dipropionate, propionate, this will become high potency corticosteroid. This is an advanced information for you, but just remember the general rule. If I have a lesion in the hidden neck or in the hidden area, genitalia, underarm, I will give what? Hydrocortisone. If I have a lesion in the abdomen, in the hand, what I will give, I have two options, either betamethasone valerate, because we have dipropionate, but we will forget about it now, or mometazone, okay? And anything in the palm and soles, you can give clopidogrel easily. Does this mean that I don't give clopidogrel in the body? No, I give. But I'm talking about the safest and the most effective, okay? What's the difference between ointment and cream? Cream, it always has, wait, let me look at the chat very quickly. Okay. Cream, they always have preservative, okay? So that's why most of the time you will find in the dermatology clinic, we don't give creams. Like we don't give betamethasone cream or we don't give hydrocortisone cream because it has preservative. Preservatives mean that they have antifungal, antibacterial, antiviral inside the cream itself. So the cream does not go bad. So that's mean a higher risk of what? Allergy. So you don't give on open wounds cream. You don't give after biopsy creams. Usually you don't give creams in autoimmune diseases. You don't give it in atopic dermatitis. You don't give it in psoriasis. I'm talking about the best practice. Is this a general rule that apply for all consultants? No. Ointment, on the other hand, is high absorption and doesn't have preservative. That's why ointment is always better in dermatology clinic. It always has the high efficacy. Okay. The magic rule to not have side effect from topical corticosteroid. If you give it for 14 days, 2 weeks, you are in the clear. You are on the safe side. Good. More than 2 weeks, you will start having systemic absorption. Like clopidogrel is very strong. You can have systemic absorption from clopidogrel, especially ointment. So after 2 weeks, you can have side effects. What side effects we have? We have atrophy, whitening of the skin, hypopigmentation, sometimes hyperpigmentation, telangiectasia. A lot of bad things can happen from corticosteroid. And after 2 weeks, you can start thinking about, should I taper, should I not? Usually, the low potency and medium potency, you don't need to taper. High potency or super potent, maybe you need to taper after 2 weeks of consecutive use. Like if you're gonna make it 3 weeks, maybe you will think about tapering the corticosteroid, okay? Why we should taper? Because sometimes the patient will relapse. You stop the immunity. We know corticosteroids stop the immunity. So when you stop it for a long time, now you take out the factor, everything will come and will come back worse. So that's why it's important to choose your corticosteroid very wisely. Okay, how much is enough? We have the fingertip rule method. So this, in Arabic, we call it anmula. This is enough for this, for 1%. So each 1% of the body part, you need only this. Okay? Maybe my hand is big. You take the patient hand as a reference. So all this, imagine, all my face, this is enough because people usually take it very aggressively. Okay? This is the general rule. We call it the one finger tip rule. Sometimes they ask in the exam one finger tip rule, how much gram does it take? This is an advanced information. But keep this near you if you need it in the clinic. Okay? And of course, he included also Abdullah, the phototherapy. You can also look at it. That concludes my talk. I didn't make it a long lecture because I want you all to understand just the basics. I have, as I told you, an advanced lecture, two lectures, introduction 1 and 2. I discuss the skin very deeply. You can have a look at it at your own time, and I will give you Abdullah's slide. Please keep it at your phone and every rotation that you go to. Study from it. It's very updated. He took it from Bologna and from Wolverton. Okay, so it's very updated, very, very nice. And thank you.
Okay, يعطيك العافية دكتور عاصم for the wonderful lecture. Thank you so much for your time and joining us today. And by the way, Dr. Asim today joined us after his clinic. So thank you so much and we appreciate you for that. And so now I will open the floor for just 10-minute Q&A session, and this part will not be included in the published recording. So if you have any questions, so I see like a lot of questions requesting the slides. We will share everything, all the slides on our social media platforms. So if you have any questions apart from the course content, which will be published, feel free to type them in the chat and like I will go over them with Dr. Asim.